while other fields in medicine were differentiating out into levels of expertise, specialties. This Women's Health Initiative study scared healthcare providers and scared women all over the world that if they were to take hormones, they would get breast cancer. It was a misreading of the actual study. The actual study never did show an increase in risk. So people that were afraid to treat women with hormones, and they didn't go down a specialty pathway. And all these years later, there's a wide variety of approaches.
You're tuned in to the Dr. Kinney Show, and I'm your host, Dr. Erin Kinney, a naturopathic doctor and speaker dedicated to unraveling the mysteries of your body and guiding you back into balance. Let's get started. Hey everyone, welcome back to another episode of the Dr. Kinney Show. This week I am joined with Dr. David Rosensweet, who has a really cool story, and I'm really excited to have him here today. We're going to be chatting about hormones and menopause and all kinds of other things. So thank you, Dr. David, for being here today.
My pleasure, Erin.
Yeah, so maybe you could start by sharing your journey. I know you've had a really cool life and journey in this health space. So share with us your story.
Well, I went to medical school in the 1960s, become a medical doctor, and I loved it. I felt like I had arrived at my temple. And near the end of medical school, I started wondering about, are there any other tools? And right out of the gate, I started studying nutrition and toxicity and exercise and also the emotions and consciousness work. And I just kept gathering tools until about the early 1990s. I had a holistic office. I loved it in Santa Fe. And Deborah, a patient I knew really well in her mid-40s, she came in and she was really upset. She didn't even have an appointment. She stormed right into my consultation room early in the morning and said, "Look, don't pretend like you know me. I'm going crazy. I'm not adding the emotions that she transmitted to me on those days. I'm going crazy and I mean it. And I don't want you to just mansplain it away." And serendipitously, so to speak, although our careers are divinely guided from my perspective, I had been speaking with John Lee, who brought progesterone into the consciousness in the early 1990s. And on a whim, I gave Deborah some progesterone cream to put on. And 3 weeks later, I got a letter from her. That's how things were done in those days. Saying that, "Oh my God, I can't believe this stuff. I feel like myself again. This is miraculous." And that was very dramatic because, as a physician, when people by the time they make it to the doctor's office, they're not doing that well. And they may have a project to do that can span months, if not years, if not decades, to recover their health. And here, something just overnight had occurred. And I was very impressed by the power of that hormone. And I never really guided my practice before I knew it through personal referrals. I was seeing a lot of women in menopause. It was right up my interest because I love biochemistry. I love biochemical pathways.
Yeah.
And I love the potency that for doing, basically you're working with women and men in their midlife. A lot of them are basically healthy. Yeah, there's some mileage on all of us. But they can fall off a cliff, as you know so well, and not be able to function, not be able to sleep, think, etc. And so I love replenishing these hormones because they make such a major difference. And I've been doing it and teaching it and going to the National Academy of Science to protect the compound chemicals.
Yeah, so thank you for doing that because it's such an amazing tool to have, especially during perimenopause. When your hormones are going all over the place and in other parts of life too. I mean, I see a lot, as I'm sure you've seen in your years practicing, when we get so stressed out, the body, I have this saying that like your body's either making sex hormones or stress hormones. And if the body's stressed out, we tend to see a decline, particularly in the progesterone and in the estrogen and men testosterone. And in some cases, if we're not able to fix the fight-flight system, the addition of, a progesterone or an estrogen or testosterone in a compounded form can be life-changing, right? Like, and in such a short time.
Yeah. And those gonadal hormones in women and men, they're primarily there for some really basic functions, including sexuality. And they will be recruited just beautifully for the biology of the fight or flight. If need be, they'll be diverted
Yes.
And women will get period irregularities and men will lose their erection, not because they necessarily tanked their hormones. They're being recruited in the perimenopause and in the 40s for the men. But eventually the ovaries stop doing it.
Yeah.
And yet we're living decades longer. So you and I both know the wonder and power and value of replenishing hormones to the right levels, the optimal levels. You don't have to replenish them to youthful levels in most women and men, but getting them to the right levels to preserve muscles, to preserve brain, to preserve arteries, bones, on and on and on.
I like that you say to get them to the right levels, because I think that's really, and this is why it's so important to work with a practitioner who, really knows what they're doing with hormones, because you can overdo it, right? You can put someone on too much estrogen or too much progesterone, and then we can see some symptoms go. I'm actually curious to see what you think. There's a doctor that practices locally, and he will sometimes, women in their 50s, 60s, puts them on a protocol and they start getting their period again. Which I have a couple of people come in and they're like, "What, should I be worried about this?" And I'm like, "Well, your hormone levels are that such. Your body thinks that it's back to getting a period." Did you ever see anything like that when you were practicing, or do something to that effect?
Absolutely. There's a belief promulgated by an anthropologist, actually, in the early 2000s, that women should keep hormone levels to youthful levels and keep their period going.
Yeah.
And she wrote a book on it, and she was a good entrepreneur, and she's really popularized it. And the concern there is, for one thing, and I wound up testing 3 different women who were on her protocol that didn't feel well, and they wanted to see if adjustments could be made. And I said, look, before we do any adjustments, let's see where you're at.
Yeah.
And I'm a big proponent of 24-hour urine hormone tests.
Yep.
And what I learned was that they were at levels of estrogens that were either 3 to 8 times the upper limit of normal of a 20 to 29-year-old. That's what it took to sustain a cycle in a menopausal age woman. It wasn't just replenishing youthful levels.
Yeah.
It had to go up to 3 to 8 times that amount. Well, what's the main downside of that? Breast glandular cell proliferation.
Yeah.
Every single cycle, as you know so well, Erin,
yes.
A woman is producing by mitosis, cell division and replication, new breast glandular cells to prepare for possible implantation and pregnancy. Yeah. And my God, you start preparing for breastfeeding every single cycle. And if you don't impregnate, then you deproliferate.
Yeah.
And the fullness of the breast starts declining as you're approaching the period. There's actual disappearance of the extra cells. Well, we think we know for sure that there's not a lot of absolute challenges to breast health that could lead to cancer. We only know a few that are absolute, and one of them is increased breast density. It doesn't mean if you have increased breast density that you're going to get breast cancer. No way.
Yeah.
But we do know it's a risk factor, and it's not a healthy breast. That's part of the reason, increased density. So why I am so adamant in most cases of not producing these youthful levels, not sustaining that period, is the risk of some woman
developing
is going to get increased breast density, and that's going to put her at risk for breast cancer. So we don't want to do that.
Yeah.
Now, we have very carefully gone to the medical literature, defined the optimal ranges, and young women vary as to how much estrogen, for example, they really need. Like some women, they're healthy, they're menstruating regularly, they're fertile at this level. Whereas other women, in order to be healthy, fertile, and regularly menstruating, they need this level 3 times.
Yeah.
So women range as to how much is optimal for them. But we've discovered very precisely that the optimal dosage range for women in menopause is just below that menstruating level.
Yeah.
Not too low. You won't preserve the brain and the vagina, but right there is the optimal zone. And I'm sorry to go on here so much, but you never say never in medicine.
Yeah.
I was testifying in front of the National Academy of Science Select Committee on threatening compounding. And I'd done some research on who else was going to be on my panel testifying. And I learned that a woman doctor was on that protocol and had her period still going. And I'm sitting down at the panel during the coffee break, setting up. And just a couple minutes before, she shows up and sits down in the chair next to me. And as she's sitting down, we introduce ourselves to each other. And I said to her, "Are you going to tell them that you're on that period-sustaining protocol?" Because I knew it was a bugaboo of the committee members. They're looking for ways to wipe out compounding. And she winked at me and she said no. And she and her son and I went out to lunch. And she was 65 at the time we went out to lunch. She said at the age 55, she's sitting in her medical office. She can't remember her patients. She can't remember their names. She's starting to not remember the medical details about them. And she's looking down the barrel of her mother had dementia.
Oh.
And her mom's sister had dementia. Both of them. And she's aware of this. And she was scared.
Yeah.
And she was saying to herself, "I'm going to have to give up practice for sure."
Well, wow.
But she knew the linkage of the importance of estrogen for brain. Yep. Pointing right to it.
Yep, right there.
And so she started taking estrogen. She started clearing up a little bit. So she took a little more, started clearing up more. She took a little more, started clearing up more. And by the time that she had cleared up back to herself, her periods came back.
Yeah. Oh, wow. So
it was very
ones that needed the higher levels.
Exactly.
Yeah.
And the medical literature tells us about this. There's studies that have shown that we can pretty much predict how much it takes to retain the health of a vagina or restore the health of a vagina. It's that low number. It doesn't take the high number. It takes below that, or how much it takes to protect the bones. It's that low number. We know what those numbers are. But the range for cognition is very broad. In your practice, I suspect is much like mine. Most women who have cognitive challenges in menopause are restored by the lower levels that we give them. They feel great. But there is that exception. So you never say never in medicine.
Yeah,
and I was so moved by her story. I had tears in my eyes. And I did not tell her, "Oh, gee, this is not safe."
Yeah.
I did not say to her that if you tested, you're going to get 3 to 8 times the upper limit. No, I did not say to her, "Look out for your sex hormone binding globulin," etc. I just nodded my head and just was grateful to the divine that she was able to, there she was.
It was feeling that good. I mean, I think at this point, it's such a cool time to be in medicine because we have so much information about genetics and receptors. And I think you need to work with the doctor to figure out what your risk factors are, right? So if you're someone who has a really proliferant risk, of breast cancer in your family, it might not be, hormone therapy going above that upper limit might not be a good idea for you. But, like this woman, she clearly it was a good fit for her. I think you're always balancing the,
always,
right? Like what's
always
for me versus what could be the downside. And I get this question in my practice a lot, like, because people read about, the side effects of using bioidentical hormones. Oh, is it something maybe I don't want to do it. I don't want it to give me, but it doesn't always, like you said, if you keep it at the appropriate levels, and we've got such sophisticated testing methods now that we can really figure out what's the right journey for you.
Yeah. There is, I'd like to back up a little bit.
Sure.
One thing you were mentioning there was that doctors ran the risk, if they don't know what they're doing, of overdosing. That does happen, and we explored that. And I see the most prevalent thing that happens is providers are so timid, they're underdosing the women, and they're following the maxim of, well, if a woman starts with a low dose and gradually increases and alleviates her hot flashes and feels better, that's the optimal dose. Well, I did a study on that. I looked at 51 patients of mine that had said to me, "Hey, I feel good. We're succeeded." It's usually at the 3 or 4 month mark that they say that. And we test 100% of the women at that time. Well, it turned out that 50% of them were on dosages insufficient to protect their bones in their vagina.
Oh,
they said they felt good. The
but they weren't at that clinical level where they were actually getting the benefit from it. I mean,
they were feeling symptom alleviation, but they were not at levels adequate to protect their bones and vagina. We know what those numbers are. And so titration is a great tool, but it's not good enough. And I think because many doctors were advised by the North American Menopause Society is testing doesn't work. That's wrong. Testing works great.
It does work great. It does.
Got to do the right testing.
Yes.
And that they said, but you can, North American Menopause Society suggests that you can, you don't need to test. The symptom alleviation will do it. Well, it won't. 50% of the women in the study that I had done, they felt great. They thought their symptoms were alleviated, but they were at not dosages sufficient to protect their bones and vagina. That's huge. And 25% were on dosages excessive that put themselves at risk for breast glandular cell proliferation. The other thing I wanted to address, and I know this is a mouthful and a mindful, but the other thing I wanted to address is you and I know so deeply that, number one, cancer has thousands of preceding causes, adversities of nutrition, of toxicity, of too much or too little exercise, or the elephant in the room, the dysfunctional and exaggerated response to the stress of life, triggering fight or flight. Cancer is not caused by hormones.
Yeah.
And we know that the science is that women who are put on hormones are at less risk for breast cancer, heart attack, and stroke than women who are not taking hormones. So we got to put all this together. And like you say, we live in a golden age in a way. Everything's not finished and done. The knowledge base is not complete, but it's rich and it's robust. And when you deal with a professional who takes this on as something that really matters, they're going to devote a lot of time and energy to learning about it and getting mentored about it. That's who the women need to find. That's their job. I always say that to women. It's good for you to know things about it, and I recommend our book, for example, if they want to learn things about it. I wrote it for women.
Yeah.
But the main job is to find a licensed healthcare provider who can prescribe these hormones, who really cares a lot about it, who's really gone for the education, seen a lot of patients, really loves the work, rather than someone who's got a very broad-based practice. They know how to prescribe hormones, but they can't keep up with it all. And so they're only reasonable at hormones.
You're preaching that's my message at every show. Like whatever you're dealing with, whether it's hormones or something else, you got to find that expert to walk you through the journey, that person that knows what they're doing and they're going to help you. Because it's hard enough as a practitioner to keep track of it all. And I think, as you said, we're in this beautiful golden age of all this information. If this isn't what you live and breathe, it can be very overwhelming. Right? So if you're trying to navigate this as the patient, as the woman going through menopause, and your brain's not working right, you don't feel good, it's very hard to be like, I don't know. So, that's why you find, someone like Dr. David or, someone who does this all the time so that you could get that support and you get feeling better. So you can go out and do your work.
Exactly. Give your contribution to your God-given gifts.
Yes.
You get to use those.
I always joke. I know my patients are better as they come in and they start telling me that, they're back doing what they love, or they're back, like you said, using their God-given gifts. And I'm like, we're on the right dose. We're on the right track. Yeah. Yeah. So talk to us about your book.
Well, I started treating Deborah in the early 90s. That was the name of the patient who stomped into my office. Yeah. And by 10 years later, I had learned a lot of things by seeing a lot of patients. The resources were there weren't a lot of places I could turn to or mentors I could turn to. And along the line, I figured out, well, the hormones are not going into my body. They're going into my patient's body. If I teach her a certain amount of how these things work and what's going on in her body, we can be a much better partnership to oscillate into the right amounts of hormones and the right balance, because we didn't even mention the balance that between 4 ovarian hormones. They're all important. So I wrote about it. And then what I found is that the women who were interested, it was a much easier process to arrive over the first 3, 4, 5 months at an optimal levels. And so I thought, because I was getting the feedback constantly from educated women who were highly motivated and educated. So in the early 90s, the early 2000s, I wrote the first edition of what later became Happy, Healthy Hormones. Now this is in the 7th edition. We keep updating it, and it's written for women.
It's great.
And so women can be part of the process. Although you said it, the main job is you don't have to learn a great deal. If you find the right provider, they've done the learning. It's like me and my auto mechanics. I used to love to want to hear everything that the auto mechanic had done. I don't want to hear a thing.
Yeah. Like,
my job was, that's right. My job was finding the right mechanic and then letting them do their good thing. So but you know, I think it is for the women who are interested, it's fun, and they can become an active part of the process, which they'll be anyway.
Oh yeah.
Not imperative, but there's a lot of curiosity. There's a lot of human beings that are scientifically minded. They may not wanted to go to medical school, but they got that kind of analytical mind.
Oh yeah.
So I wrote the book for the analyzers amongst us.
That's great. Oh, and I get a lot of patients that, you know, are very well versed in, you know, because they've been through a journey and they've had to kind of learn. And if you're working with providers that don't listen to you or don't take very much time with you, you kind of have to spend some time to it. So it's good to know what's going on. It's great to have resources like your book out there to, you know, read. But it never takes the place of having that, you know, that provider, you know, can walk with you on the journey. Yeah. So tell me about your favorite testing ways. I'm curious to hear, like, what you said. You mentioned the 24-hour urine. How else do you like to?
Yeah, that's it.
That's what you use.
I mean, I do, and I'm, you know, it's like it's a religious conviction for me at this point now, 25 years into doing that, and I definitely have tried the others. And actually, our field is very unusual, and you know this, that when you go to any other branch of medicine, you see specialists who are highly trained. They've gone through residencies. They've seen hundreds and hundreds of patients, and they're mentored. Take a urologist, for example, or a diabetes specialist. These people, that's what they've hunkered down on. Our field is very different.
Yeah.
And I think a lot because while other fields in medicine were differentiating out into levels of expertise, specialties, along comes the 2002 tremendously deleterious blow to the world of hormones. This Women's Health Initiative study scared healthcare providers and scared women all over the world that if they were to take hormones, they would get breast cancer. It was a misreading of the actual study. The actual study never did show an increase in risk.
Yeah.
They even stated in the study that there's less risk with Premarin, and the 1.26 relative risk with Prempro is statistically insignificant, but that's not what the press got a hold of. Press got 1.26. Oh, there's an increased risk. And it just stunted our whole field of interest here and enormously. So people that were afraid to treat women with hormones, and they didn't go down a specialty pathway. And all these years later, there's a wide variety of approaches because there is no standard of care, although our group has been working on standard of care for 15 years.
Yeah, thank you.
And yeah, we're definitely, we're at board certification time, and we're doing studies. So in the world of diabetes, there is no discussion about the testing. They got excellent testing tools, and they're highly sophisticated, and they're in 100% agreement with what those tools are. Yeah. And nowadays, God, you can even get a glucose continuous monitor.
They're very cool. I've used one. Have you tried one?
I haven't tried one, but I need to try one.
Yeah, it's in there. It is a really fascinating, and not the topic for the show, but it's a really cool experiment. It's like real-time data. You can be like, oh, look, that, and I would just found it so interesting, like what exercise does to your blood sugar, what stress does to your blood sugar, what, things other than food. Anyways, other topic. Sorry.
Well, it's a great topic.
Yeah.
Well, That's not true. And diabetologists are not going to argue, no, I don't think you should do that. They're gonna,
like, that's great.
They all got their standard. And that's not true in the world of menopause. There's been all these rising up of different ways to testing and testing women that you're treating, and they've all got pros and cons with them. And there's some testing methods that, in my experience, they're not okay. But we're not going to blast into that. I'm not going to go further. Our group, and we've got a medical board of directors, we got active people in this. We're doing comparatives. We're split specimening. We're sending an individual woman's who we're testing. We're sending her out to 5 different ways of testing her, those who are volunteering for this. And same with men. We're doing it with men too. We're sending it off to 2 24-hour urine hormone tests. We're doing it to 5-point urine testing. We're doing it to saliva, and we're doing it to blood. So any individual woman on a given day, when it's time to test her, we're at our own expense going out and trying to figure it out. And we've got a laboratory expert, an MD, PhD on our board of directors. He's actively involved. This gynecologist actively involved. So we hope to report this out in about 6 months.
Okay.
And what I get, so right now I'm going to tell you, without addressing the other testing methods, by far, 24-hour urine hormone testing, it's gorgeous. It works. It really correlates clinically. And I've gone so far as to be able to define, well, what is the optimal amount for women for estrogen?
Yeah.
This is young women. So when I did that, I found this from the medical literature. What's too low? If you're not putting out 8 micrograms of some of estrone and estradiol, your bones, you may feel better, but your bones are not getting what they need. And the upper limit, if you go above 14, you could feel good, but you're at risk for breast glandular cell proliferation. No problem. If you have to go above 14, we just monitor the breast, because the cancer is not being caused by the estrogen.
Yeah.
At worst, it's increased breast density. We don't know that you're getting increased breast density from those levels.
Well, so this is and you look at all the other different risk factors for the individual person.
Exactly.
Like this is where you make the decision based off of that.
Exactly. And we've got tools to monitor. If you need a more robust level of estrogens, well, we more robustly monitor breast health.
Yeah.
And we'll even bring in thermography, which is not okay for assessing breast cancer risk, but it does reveal inflammation.
Yeah.
And that's a big deal. We don't want to see inflammation going on in the breast.
Yeah. Well, it's so interesting to me. When I think about hormones, I always think about, and not that we really have a way to test receptors, but, there's receptors for hormones everywhere, which is why we get all these crazy symptoms for different hormone levels. And, so maybe there's a combination of testing that's possible. Like you need to test the blood and the urine and the saliva. I don't know. I always think it's interesting.
Yeah.
That there are
sometimes
so many different places.
I mean, I find that we can.
I think it's nice for medicine to have a standard testing thing that people aren't arguing. Yeah. Everyone can be like,
and we're out to see what testing works and what doesn't. And our data is showing that some testing is not working. Yeah. It's not correlating. And there is blood tests that we need to do. We need to test sex hormone binding globulin, which can go awry. And in the challenging cases, in the non-challenging cases, and by that I mean, okay, it may take time, there may be complexities, it may take 3 to 5 months to sort it out, but it's not rocket surgery. We figure it out together. And you've probably done hundreds of these.
Oh yeah.
And it's just a matter of taking one step after another. But occasionally there's a case that doesn't make sense. And we like to expand our testing into, well, what's getting thrown off here? Are there receptor problems? Oh my God. Are there detoxification problems? Oh my God. Are these receptors being occupied by toxic chemicals? Oh my God.
Infections, or, there's all kinds of things that can,
Yeah.
You said that, they're getting recruited for stress hormones. And I've seen some cases where, we've put women on hormones and it's like their levels don't improve. And usually they end up having Lyme disease or something else. And their body just continually is recruiting even the prescriptive hormone over to the stress hormones. And so then we got to address the other issue. But
yeah,
another topic.
The power and value of going to someone who's been educated.
Yes.
Some experience.
Yes, this is very true. Very true.
Yeah.
So this has been a great chat. We'll put the links in the show to your book and to your website. Where else can people find you if they're interested in learning more about you? You're still practicing, right? Are you still taking patients?
Oh yeah.
And you work.
Well, I'm the main thing I do is I train and mentor physicians and nurse practitioners.
Amazing.
To get excellent at this, to specialize in it. And that's the main thing I do. I still keep a certain number of patients I've worked with for years because I want to be involved in the front lines.
Yeah.
But I'm not taking too many new patients. My commitment, I'm still working 50 hours a week.
Yeah. Teaching.
But I don't have room.
Yeah.
I think I can have more benefit by doing things like this with you, for example.
Yeah.
And, as you and I discuss and reach out to your audience, and I think this is more valuable. And protecting compounded bioidenticals, I've got a lot of action going there. And
well, question for you. So for my listeners, if they're looking for a practitioner to start working with, where would you send someone? Like if they're like, hey, find someone who's trained in this. Do you have a good resource?
Yeah. I mean, I would start with what's in our book is our email address.
Great.
And we have a woman on our staff who knows everyone we've trained. She knows every state that they're in. Okay, and I think our people, I really respect them.
Yeah.
And then if it's not easy, the next thing I'd recommend is talking to your compatriots, your friends.
Yes.
Because someone in your friend group is probably on bioidenticals and has gone through the shopping process and knows a good one.
Yes.
And then there's 8,500 minimal compounding pharmacists in the United States. These are the ones who are filling the prescriptions of providers.
Yeah.
And they in their own town, they're not just filling the prescriptions of one provider, they're filling the prescriptions of 10 or 20 or 50. So if you go to that compounding pharmacist, walk in there, talk to them. These are some of the most informed and friendly pharmacists on the planet.
I have such a good relationship with the couple that we use. And if I have questions, I sometimes am like, hey, can I ask you a quick question?
Yeah,
and
right.
So much. They're like, oh, so-and-so's doing this with their patient. I'm like, oh, okay, cool.
So that's what I recommend to women is go to your local compounding pharmacist in person.
Yeah.
Because they're busy folks.
Yep.
But they'd love to talk to people in person mostly.
Yeah.
And say, look, here I am. I'm in menopause. I need help. Who would you recommend?
Yeah.
Because these compounding pharmacists, they know the physicians who are new to the game and just learning,
doing a long time.
and the ones who are really doing good work, and the prescriptions the pharmacist receiving, the pharmacist will say, oh, that doctor knows what's happening here.
Yeah.
They're very sophisticated in their prescribing.
Well,
those are some resources.
Yeah.
Yeah.
Yeah. Thank you. Well, so anything else you want to share? Anything else, little clinical things or anything?
Yeah. There's a temptation to think, well, I'm going to go natural. Well, let me tell you what natural is. You wind up, these hormones stop. And these are the most powerful biochemicals in our body. And as physicians, you and I have the vision of being able to know, okay, this is what happens to human beings in their 40s and their 50s and their 60s and 70s and 80s and 90s. And I can tell you, folks, if I had to make a wild guess, I'd say 98% of all human beings on this earth, their hormones from the age of 20, when they're peaked, decline close to zero by their 80s. Consequences are huge. You pretty much guarantee to get osteoporosis and become tremendously vulnerable for life-ending fractures, although they may be extended for a year by sophisticated operations. Most people, that's one of the final blows is that fracture. You lose your muscles, guarantee sarcopenia. Older people, they don't stand well, and they walk and stand and walk with instability, and they go to canes, then walkers, then wheelchairs, and that's quite a transition there to the wheelchair. For many people, that's the last time their family's able to really take care of them. And so I was talking to another doctor that you know probably pretty well, Dr. Bergson. She and I were trying to guess what percentage of women and men in assisted living facilities do we think are there because of low hormones? We are guessing 80 to 90%. Sarcopenia, muscle loss, wheelchairs, adult diapers, where they're getting incontinent because women have lost their vaginal health and their bladder control and their cognition.
Yeah.
Cognition. That's why they're there. And so these things creep up on folks very slowly. And I say, the moment you get inspired, even if you're in your 80s, there's you require special care. But even if it's in your 80s, I've treated women in their 80s who decided to take hormones to advantage. So the earlier you can think about this, you can explore and come up with your own idea, but your information about risk is false, most likely, if you're scared of hormones. The hormones are protective in both men and women. And my recommendation is get on early.
Yeah.
It's so much easier. What you say, Erin, it's so much easier to treat a woman in the perimenopause than when she's starting for the first time in 80, when she's 80.
Yeah.
So you're going to want to, your life is going to mean, I'm talking to the audience, your life is going to mean as much to you when you are 90 or 80 than it does right now. And yes, you'll adjust with courage and bravery and fortitude to the health costs of not having hormones, because it's almost guaranteed the costs are going to be enormous. But that's not what you're going to want. You're going to be walking and talking and conversing and thinking and enjoying your life with vitality and vaginas and sexuality even.
Yeah.
Men with erections. How about that? Do you think erections are going to be important to a man when he's 80?
Yeah.
Yes, they are. And so the best time to do it is get on the train early. And even if you're not, even if you're in your 70s and you haven't had hormones for 20 years,
you can still,
or your 80s, you can still do it. It requires special focus, but take them hormones.
Yeah. Great. Well, that's great. Thank you again so much. This is a great chat. And if you guys are interested, again, we'll put all the links in the show notes on how to learn more about his book and put the resources in there for them to find someone if you're interested in starting to get on some hormones. So thanks, everyone. And we'll see you next week.
All right. So nice to talk to you, Erin.
You too.
Thank you for tuning in today. If you enjoyed this conversation, be sure to connect with me on social media and leave a rating and/or a review. This helps grow the show so more people have access to this knowledge that leads to empowered healing. Love and light, and see you next week.